of the lymphocytes so that the virus will not be able to attach and fuse into the cell and infect it. That's the theory behind it. Now, from this observation in the test tube, this substance was tried in Israel anecdotally in some AIDS patients, and it was tried in our institution in 7 or in 8 people who had lymphadenopathy. These people were not symptomatic at the time that they enrolled in the study. They had, however, on 2 occasions before they started the material, they had a positive virus culture, not a P24 antibody, but the virus was cultured by a process called co-cultivation, and the presence of the virus was assessed by the level of the reverse transcriptase that Dr. Laurence mentioned as well. During the first 2 months of taking this drug, there was a decrease in virus recovery based on the reverse transcriptase assay in 5 out of these 7 people. The trial was planned to stop the medication after 2 months, which happened, and the patients were followed without AL721 for another, or are followed actually until this day. They remained off the material for 5 months. After 2 months off, the reverse transcriptase reappeared in 4 out of the 5 where there was a significant suppression in the reverse transcriptase. Now, I think it is very important for you to understand that this was an incredibly small study and that you cannot really make any type of predictions based on such small numbers. And what I have to point out is that it has become very obvious to us, we are the clinicians taking care of the patients, that it is not easy to make this substance because the batches that have been delivered to us to give to the patients seem to work differently, they appear differently, and there have been great problems because one of the big questions that has come up, why hasn't this been tried in more people? We waited in the first place for 3 months extra before we were able to start even our 7 patients, and it had been planned to treat 11 and 11 in England in Dr. Pinching's hospital, who's a very well-renowned British AIDS researcher, and the material could not be delivered because there were problems with contamination, with bacterial count, and this has been a persistent problem that has dogged this particular product. So that what I say sort of on the follow-up on this, I think has to be interpreted as that it's really non-interpretable results. Of the 4 people in whom the virus came back during the 5 months in which they were not taking the AL721, 2 during this period of time after the virus came back progressed from a relatively asymptomatic PGL stage towards full-fledged AIDS. 1 patient developed lymphoma and 1 developed pneumocystis. All 7 patients were restarted on a different batch of AL721 on February 1st of this year and have continued to take substances, but as I say, it is at this point that we've had trouble with different batches. And to indicate to you that, because as Dr. Laurence indicated, there are indeed problems with how we should measure the virus. With the AZT, we know that virus on co-cultivation by RT generally does not disappear, but the P24 antigen, as measured in the serum, it comes down in about 70 to 75% of patients. We measured P24 antigen with this particular compound, and found that 3 out of our 7 patients had been persistently negative for P24 antigen before they started the drug and during the whole course through. 1 patient had P24 antigen at the beginning and became negative and has remained negative, and 3 people have been persistently positive before and during the whole time they have taken AL721. So clearly, if this compound has any effect at all, which I think is very unclear at this point in time, it is not reflected in the P24 antigen. there really is not much more to be said about AL721 from a scientific point of view at this stage. I think that the suppression with some of the batches that we have used of RT appears to be real, of co-cultivation. I think in order to find out whether this drug, number one, prevents progression from PGL to AIDS is very, very unclear at this time. Certainly we have not seen any increases in T4 cells, which I think is a very significant finding. Also, I think again to point out how unsure we are about what P24 antigen in the blood and virus on co-cultivation means, I have to point out that after restarting all of our patients, one of them who has been persistently negative for P24 antigen has progressed towards PCP 2 months ago. Now, the other drug that I was asked to say a few words about is imuthiol. I think imuthiol is in many ways certainly a substance on which there's a tremendously larger body of published data as well as preliminary data available. It is a chelating agent that was developed by the Institut Mérieux in Lyon, France. They have worked with this compound for more than 10 years. They have found that it works very well. A chelating agent is a substance that binds metal ions and removes them, so that this substance is known to work quite well in nickel and in copper poisoning. Nickel ions are known to be quite carcinogenic, so when nickel was given to animals together with imuthiol, the development of cancer was suppressed. The substance is an analog of antabuse, but it has very, very different pharmacokinetics. So thus, it disappears. The half-life or the time that it is found in the blood for imuthiol is 20 minutes versus 14 hours for antabuse. The protein binding is very loose for imuthiol, whereas antabuse is very heavily bound. And the in vitro, in other words, the test tube, as well as the animal experiments that have been done with imuthiol were done with a number of other substances, including antabuse and control, and the effects that were shown with imuthiol were not shown with antabuse. The animal data, there's a classic animal model known as the nude mouse. It's called nude because it really has no hair and looks pink. And it is a model where there's a congenital defect for T cell or cell-mediated immunity, which is the defect that results from invasion or from infection with HIV, and that we find when we have AIDS. By giving imuthiol to nude mice, a certain degree of cell-mediated immune deficiency was restored. And there's another model called mouse model called the New Zealand black mouse, which is a classic model for an autoimmune disease called systemic lupus. The development of systemic lupus was also delayed when the mice received imuthiol. Now, this substance was first used by Professor Jean-Marie Lange at the University of Strasbourg 4 years ago. And there was a double-blind, placebo-controlled study done and presented at the June meeting in Washington. What first got me interested in this drug, and the reason that recently I had to go to Europe for a scientific conference, and I visited this professor as well as I visited the Institut Mérieux, was that on the poster in Washington of more than 100 people who received this drug in a placebo study, there were 4 who had received it for more than 3 years. And 2 of those 4 had less than 150 T4 cells at the time they started the drug. And after 6 months of receiving imuthiol, in both cases went above 500. What intrigued me the most was the fact that the effect was sustained, so that both these people had the cells came down somewhat, but the T4 cells remained above 300 over the 3-year period. Now again, I want very much you to realize that this is a very, very small number, and I went to France to find out if they had studied more people, and they're in the process of doing several more studies. And there's also a placebo-controlled study going on at certain centers in the United States, in Texas, at the University of Arizona, in San Francisco, and at UCLA and at Duke. There is a response, but there's not a response in T4 cells in everybody. I don't know the exact percentage, and I talked to Dr. Caro, who's the coordinator of the Mérieux Institute this morning, and he said it was too early to give a definite percentage. I think that it is fair to say that what has been shown, I mean, the drug has been used for more than 3 years. The trials are undergoing very close scientific scrutiny, and that at this stage it's fair to say that this is in many ways a promising agent that deserves to be tried further, but again, that we don't have a real answer. Is it going to help in the long run? Is it going to prevent the progression from PGL towards ARC and AIDS, and so on?
I'd like to ask Dr. Bihari to talk about antabuse and then about naltrexone.
Okay. I'm going to spend most of the time talking about naltrexone, and then briefly antabuse, since Dr. Lange covered imothiol and mentioned antabuse. The role of naltrexone in the treatment of AIDS is based on growing evidence in recent years that endorphins and opiate receptors, endorphins are the body's own natural substances that resemble morphine, heroin, codeine, and that play a major role in the body's ability to deal with stress. There's growing evidence in the immunology literature that endorphins play a major role in the body's homeostatic regulation of the immune system and in communication between the immune system and the central nervous system. In fact, most immune functions in the test tube are significantly affected, mostly positively, in the presence of the proper amount of the appropriate endorphin. Based on that, about 2 years ago, my colleagues and I at SUNY Health Science Center at Brooklyn and Kings County Hospital began looking for a method for increasing endorphins as a means of attempting to enhance immune function in people with AIDS. And we looked at naltrexone, a drug which we were quite familiar with because we've been using it for some time in the treatment of heroin addicts. Naltrexone was marketed about 4 years ago as an adjunct in the treatment of heroin addicts. It works by blocking opiate receptors such that if the heroin addict takes 50 milligrams a day or 100 milligrams every other day, he can't get high on heroin unless he takes huge amounts. And it had been noted with naltrexone in animal studies that it induces the pituitary gland, and in humans, it induces the pituitary gland to make much larger amounts of beta endorphin, one of the body's major endorphins. It also triggers an increase in the number of opiate receptors, the endorphin receptors, in various tissues in the body. Both of these are the body's attempts to adapt to the blockade of the opiate receptors, making more endorphins and making more receptors. And we found one study in which very small amounts of naltrexone in an animal model produced an increase in opiate receptors and in endorphins without at the same time blocking the opiate receptors. And translating that, we started about 2 years ago a double-blind study with 38 patients with AIDS using a small dose of naltrexone, large enough to enhance endorphin production, small enough not to block its benefits. Half the patients got naltrexone and half got a placebo. At that point, we used 1.75 milligrams once a day at bedtime, about a 30th of the dose used to treat heroin addicts. We're currently using 2.75 milligrams once a day at bedtime. During the 3-month double-blind period, of the 19 patients on naltrexone, all 38 already had full-blown AIDS. Of the 19 patients on naltrexone, none had a major opportunistic infection. Of the 19 patients on a placebo, 5 had major opportunistic infections during that 3 months. Also during the 3 months, we discovered unexpectedly that the very high levels of alpha interferon that we had found on admission in the blood of all of our patients, that those levels dropped significantly in the patients on naltrexone, and they didn't drop in the patients on placebo. After the 3 months, we put the placebo patients on naltrexone and followed both thereafter. And we found that over time, lumping now both groups together, that about 2/3 of the 38 patients, or 23, had a marked drop in interferon levels from an admission level of an average admission level of 160 units, international units, to a level after 8 months of 11 international units. Now, interferon is the body's own potent antiviral substance, which the body makes after virus infections. After the ordinary viral infection, your blood level goes up to 8 to 12 international units for a few days, and then comes back down to 0. In people with AIDS, in over 80% and in 100% in our study, the interferon levels are much higher. They're high enough so that comparable levels in animals and in cancer patients treated with recombinant alpha interferon produce immune suppression. In fact, immune suppression sufficient to lead to Kaposi sarcoma or opportunistic infections have been reported in cancer patients treated with high levels of alpha interferon. And it's our feeling, as it is of some other people interested in interferon research in AIDS, that once the alpha interferon level rises in people with AIDS, it may be a secondary contributing factor to the progression of the disease, and that bringing it down may benefit patients. In fact, in our study, that really seems to be the case. Of the 15 patients whose interferon did not drop on naltrexone, 13 had died within 9 months. Of the 23 patients whose interferon levels did drop down to a good antiviral level, only 4 died in the first 12 months, and after 18 months, only 6 of the 23 had died. So there was a dramatic difference in the survival between those two groups, the people whose interferon dropped on naltrexone and those whose didn't. In addition, there was a marked difference, and quite significant, in the number of major opportunistic infections between the two groups. Those whose interferon dropped had significantly fewer opportunistic infections than those whose didn't. One of the benefits of naltrexone is that at the doses we're using, it has absolutely no toxic effects. In fact, at the much higher doses used in treating heroin addicts, the only side effects are some depression, anxiety, and insomnia, which clears within 6 to 8 weeks. At the dose we're using, the only thing we found is about 1 patient in 20 finds that if he takes the dose at bedtime, he has trouble falling asleep. If he moves the dose back an hour or two, that's not a problem. And another benefit is that naltrexone is already on the market, and therefore can be prescribed by any private physician for any private patient. And in fact, a number of physicians around the country, at least 50 to our knowledge, are treating their AIDS, ARC, and immunosuppressed patients with low-dose naltrexone. And our study just involves AIDS, and nobody's done a study with ARC or immunosuppressed patients. However, I did treat one friend with ARC starting 2 years ago with low-dose naltrexone. At that point, he had mild to moderate ARC symptoms and a T helper count of 300. His symptoms cleared, and his T helper cells are now 600 2 years later, with no progression in any of his symptoms. And a number of the physicians around the country have reported to me that patients with ARC, especially with milder ARC, and patients who are immunosuppressed, have shown significant rises in T helper cell counts. That's anecdotal and is not scientifically reportable. However, clearly our work needs to be repeated by other researchers for it to be widely used. The National Institute on Drug Abuse, which first developed naltrexone as a treatment for heroin addiction, is in fact, will soon be beginning a large double-blind study done in collaboration with Johns Hopkins in Baltimore of healthy seropositive patients with low-dose naltrexone, followed over a long period of time to see if those who get naltrexone have the progression of the illness affected. Now, briefly about antabuse. The interest in antabuse is because of its relationship to imuthiol. I've reviewed the results of the imuthiol study that was reported at the conference in Washington in June and was quite impressed. And my own feeling is, being aware of many treatments that are in progress now, that it's probably one of the most promising that is in current phase 2 trials. Antabuse, in fact, according to the pharmacology textbooks, is converted, 90% of antabuse that is ingested is converted to imuthiol in the body. Based on that, and on the fact that antabuse has been on the market for 35 years as an adjunct in the treatment of alcoholics, and is an essentially non-toxic substance as long as the person taking it doesn't drink, many physicians in New York and San Francisco have begun treating patients who are not able to get imuthiol with antabuse instead, using 750 milligrams 1 day a week or 500 milligrams twice a week, a total dose which is much smaller than the dose used in treating alcoholics. Its use began in this fashion just 2 months ago, 2.5 months ago. One of the physicians in New York who started a patient about 10 weeks ago on antabuse has reported that this patient's T helper cells have risen from 200 to 400. But we won't know for several months whether the results with antabuse at all compare with the results with imuthiol. The Community Research Initiative of the People with AIDS Coalition is doing a study collecting data from private physicians who are prescribing antabuse, and we hope within 4 to 6 months, the Community Research Initiative hopes within 4 to 6 months to have some information about the response of patients to antabuse and whether or not it seems comparable to the response to imuthiol. Now, I'd like to make just one more comment. We've all been presenting the results of research, and when one speaks as a scientist, you really can't go beyond your data. In fact, as a scientist, I can't recommend wide use of naltrexone, as Dr. Lange is not recommending widespread use of AL721 or imuthiol, etc. However, as an individual, I think this is an important point to make. If I were seropositive, I personally would put myself on low-dose naltrexone, imuthiol, or if I couldn't get it, antabuse, and AL721. Each has some scientific basis for suggesting it may prevent progression, and each is non-toxic. And in fact, 2 of these 3 substances have been in wide use for a long time in higher doses, and so we're quite familiar with whether or not they have adverse effects over a long period of time. Just one more comment. I do have some written material that the Community Research Initiative has prepared on antabuse and its relationship to imuthiol and the imuthiol results, and some on naltrexone if people are interested at the break or at the end.
Why don't we agree to put that material on the information table that is out in the lounge area during the break. I'd like, before we start the open discussion part on treatments, I'd like to mention once more to the panelists, please try to, when you speak directly into a microphone so that we get a good recording of this. And I know that Laura has a question that she would be interested in addressing to the whole panel.
We'd like to ask the entire panel to follow up along the lines that Dr. Bihari ended his comments with. We understand that as scientists, the data that are available on these drugs are not the data are not yet conclusive. But we'd like to know what you would recommend to individual patients. Lots of people are taking AL-721, lots of people in New York. A number of people are taking naltrexone, antabuse, and in California, imuthiol. What do you think of this practice? Do you think that there are dangers to it? Do you think that it's a useful thing for people to do who don't want to sit and wait until the clinical trials are done?
Hot potato.
I know of no drug that is non-toxic. And when you combine drugs, toxicity tends to increase. Now, I understand what was said, that this is a very difficult disease, that we have no ready treatment for it except for AZT, and that it is reasonable for people to consider to take alternative treatments. But I don't believe that people should take those alternative treatments with the idea that they will be non-toxic. There is no drug that I know of that is non-toxic.
The real question of Dr. Bihari was what if you were, or you myself was HIV positive, would I take? And I can honestly say, with the present information available, I wouldn't know what to take. It's like playing Russian roulette. I can perfectly well sympathize with everybody who's HIV positive wanting to take something. But for me to come out and say, I think you should take one of any of the 4 substances discussed here tonight, I don't have a clue. I don't know whether AZT in an HIV positive PGL or asymptomatic setting is going to do anything at all. Counterbalanced against that, you have the fact that AZT is indeed a fairly toxic drug, and that we have absolutely no idea what this drug will do if you take it for a year or for 2 years, because the idea is that none of us even believes theoretically that any of these substances will cure. We know they will only suppress if they will do that, and that is very unclear. For that reason, I think that knowing that that the U.S. Public Health Service tells us that we're supposed to have 275,000 cases of AIDS by the end of 1991, which means 233,000 more than we have today, and that's 4 years and 1 month away, is that I think a concerted effort has to be made to start several substances simultaneously in groups of people who should probably be stratified based on ranges of T4 cells. Since we don't know what is the best test to measure that will response, whether acid-label interferon or P24 or co-cultivation being the most difficult one to take, I think that we should probably pick a battery of 5 or 6 tests that should all be tried, because we don't know which one will be better. And I think that if something like this were available, there certainly are enough desperate people, probably in this room and certainly outside, who know that they are HIV positive, who have for 2 or 3 years seen their T4 cells sinking, who know very much what is ahead of them, who would most willingly be willing to go into any of these studies. What I'm very unwilling to do is say, take AL-721 or take imuthiol. But I think a concerted amount of work and pressure in the right points without any hysteria could potentially start off simultaneous trials of a number of these substances.
I'd only like to echo what Dr. Lange and Dr. Armstrong said. If we were having this discussion 2 years ago, we wouldn't be talking about AL-721 and thiol and antabuse, and naltrexone. We'd be talking about Suramin, and who remembers that? We'd be talking about HPA-23, and who remembers that? We'd be talking about azamexon. We'd be talking about danazol and so forth. I think we need more clinical trials. We need them done faster. I think we have to answer a lot of questions that were raised here tonight. I'm just very concerned not only about toxicity, but also combining things. As I mentioned before, even something that works in a limited number of people, AZT, you start taking all those individuals who are going to Santo Domingo and Tijuana or West 43rd Street and getting ribavirin, that were combining it with the AZT that they were taking already and really doing themselves harm doing